Welcome, everybody. Good evening to all of you in India. Good morning for those of you here in the US, and possibly good afternoon for people joining from Europe. I'm Venkat Narayan, and it's my pleasure to introduce my friend and colleague, Dr. Nihal Thomas. Nihal is head of Unit of Endocrinology at the Christian Medical College in VELLORE, India, a very premier medical school in India. And he also, has been long associated with the VELLORE birth cohort, has got his PhD in endocrinology and epidemiology from University of Copenhagen, working with a number of colleagues that I know there. And the other thing that I share with Nihal is that we are both products of the same school in Bangalore. So again, he's a lot junior to me, but we share that camaraderie and bond. I don't have to introduce Nihal much, but I can tell you this. Nihal is one of these people who has beautifully combined clinical medicine, clinical research, epidemiological studies, and very basic research to look at a problem in a very focused manner. And he's really studied the issue of diabetes in lean South Asians, and this lean phenotype could apply to other populations across the world who are also experiencing high levels of diabetes in that population. But more importantly, aside from the leanness, it begins to give us some very specific insight into what might be causing diabetes overall. And I think you're going to have a wonderful talk which combines his work in epidemiology, basic sciences, and clinical research. It's my pleasure to invite Nihal. I can already see nearly 70 people have logged in from across the world. And a lot of people have also asked for his recording. So this is going to be a very thoughtful seminar. So Nihal, thank you for taking the time. I know it's late for you in India, but why don't you take it away? If you can give Mark 30 seconds. Mark, let us know when we can start. Mark, can we mute everybody?
You can go ahead. Yes.
Nihal, you can take it away.
Thank you, Venkat, for that introduction. And it's a real pleasure and a privilege to be with all of you here today. I think whatever that I've done, I would like to first acknowledge the institution behind that logo that you're seeing on the screen, Christian Medical College, VELLORE. A lot of people who worked with us in the department over the years, and several collaborators from within India and, of course, overseas as well. So I'll be talking to you about lean diabetes in India. And the question is, what does it mean? So they say it's genes, not the blue variety. Environs have a role, and the lack of satiety. Epigenetics, low birth weight, problems for poor, dwindling secretion, and resistance for sure. So I'll be starting off, and I do believe that the audience that we have today is fairly heterogeneous. I'm going to run through some clinical cases, some which are going to be pretty obvious to you, and the other which are going to be cryptic, and then come to the diagnosis a little later on. We'll talk about epidemiological trends in the region where I live at, and the effect of the environment and other factors, looking at the pathophysiological impact of the Barker hypothesis. Now, this is an area which raises much debate, low birth weight and its impact on the human being, and aspects of how the thrifty phenotype, in fact, may have an impact on health per se. We can have a long debate on that. Hypoglycemia diabetes, a disorder which is unique to the tropical regions and is still very much a problem in India. The monogenic disorders with lean diabetes, the overlap, and finally, this very contentious area, a condition which is described and entered onto the WHO classification way back in the late 1980s and was removed in the late 1990s for lack of substantiation or physiological proof that such a disorder really existed. So this is going to be really simple. because I want to take it from the very basics and then take you on to the physiological and the genetic aspects of disorders. This is a 37-year-old man who came with hypothyroidism for 2 years with some carbimazole, had diabetes for 2 years with osmotic symptoms, was started on oral anti-diabetic agents, but changed to insulin within a year. He complained of weight loss, increased appetite, polyuria, and polyphagia, and no past history suggestive of diabetic ketoacidosis. There was no family history. He had a lean habitus. His BMI was 16.7 kilogram per meter squared. He had a palpable goiter, and the systemic examination was otherwise normal. So, based on the physician who was looking after him did abdominal imaging, which is normal, and then asked for the antibodies. The GAD antibody was strongly positive, and the fasting C-peptide was low. So he also had hypothyroidism, as you can see over here. The TSH was suppressed, elevated T4, and here we have a diagnosis of a man past the age of 30 with slowly evolving immune-related diabetes. Now, the other cases, in terms of what we're looking at over here, may bear some similarity. But just very briefly, we are dealing with a disorder which has an autoimmune phenomena, but is a little different from type 1 diabetes, which generally has a single antibody positive and may have some features of insulin resistance at the same time. If you were a primary caregiver treating diabetes, you might say the next few patients have exactly the same problem. And that's what happened. Over a period of time, we have seen a number of patients who have passed through the net, wherein a diagnosis of type 1 has been made and they've had treatment for type 1 diabetes. A 33-year-old gentleman, a laborer with abdominal pain radiating to the back for a year, weight loss, which is fairly significant. He's got diabetes, which is initially on oral anti-diabetic agents, and no history of smoking or alcohol. Once again, he's lean. There's no evidence of nutritional deficiencies, and per abdominal examination, just revealed mild epigastric tenderness. 16-year-old girl diagnosed to have diabetes during routine testing on thrice daily insulin, a recurrent history of renal stones with chronic renal failure, which was in fact her primary presentation. She had had a stenting and a lithotripsy. From the age of 14, she had cyclical lower abdominal pain every month, no steatoria, and her mother had pre-diabetes, and a paternal aunt had diabetes. Her BMI was 21.2, and her Tanner staging for the breast and pubic hair were reasonable. 38-year-old lady diagnosed with diabetes at 19 years of age, present with hyposmolar symptoms. On examination, he was also diagnosed as type 1, had a lean habitus, enlarged veins present on the limbs, markedly reduced subcutaneous fat, and fundoscopy showed evidence of moderate diabetic retinopathy. So all these patients in primary and secondary care, a diagnosis was made of type 1 diabetes. But were they really that? Many references mention lean diabetes as a BMI of less than 25 kg per meter square. But the word lean, I would like to say, is more of a layman's term. It's a spectrum. And if you go by the WHO classification, we'd like to say that lean is less than a BMI of 25. If you go by the Indian cutoffs for the trajectory for insulin resistance, cardiovascular risk, we talk about a BMI of 22 or 22.5 kilograms. If you talk about frank malnutrition, you mean a BMI of less than 19 kg per meter squared or a BMI of 18.5. So we really need to be extremely careful when you talk about the word lean. And I'm going to veer towards the left more than ever, talking about lean, talking about BMIs which are generally less than 21 or 20. And that's what I mean by lean today. So a little bit about the epidemiology in this part of the country. We all know about the landmark studies which have looked at the prevalence of diabetes in India, the INDIAB study, and subsequently this publication in the Lancet, which has talked about the progression of diabetes across the country over a period of the last 3 decades. There's this wonderful article in Diabetes, which was published and looked at the Indian phenotype, talked about it being a condition wherein there's more insulin resistance. In addition to that, they have prominent extremely low, and they're much more prone for coronary artery disease at an early point of time. And of course, Yagnik's term of thin fat has also been adapted and put into this article. But when we talk about lean diabetes, is it all this or is it much more? So let me tell you where I belong geographically. This is a town which has a population of around 590,000, which is located between two megapolises, Chennai, which has a population of about 11 million, and Bangalore, which has a population of around 13 million. So this is what one would call a level 2 town in India. And perhaps you'd expect the prevalence of non-communicable disease to be a shade less in terms of influence, in terms of environment, etc. Now, here are some of the studies which have been performed back about a decade before, looking at school children in VELLORE town. And what we found is that they had a high prevalence of impaired fasting glycemia, around more than 20% in males aged between 14 to 17. The body habitus of these children, done in another study, showed quite clearly that there was a high risk of these children having a negative body habitus in terms of an increased waist circumference, elevated diastolic blood pressure, systolic blood pressure, and lipid anomalies, which was related to weight circumference. And if both parents had this problem, then the influence was much more stronger, and the odds was almost 6 times greater for the child having a metabolic problem. We've had an interest in doing epidemiological studies in certain other parts of the country, and the northeast part of India is, in fact, a good 2,500 kilometers from where we are. And because of our network of peripheral rural hospitals, we have had this interest of looking at the epidemiology in these areas. And even in an area as remote as Tripura, which is a rural area over here, we found that the prevalence of diabetes in a rural area, and this was about 15 years ago, was around 9%. And the BMIs of these individuals also veered towards less than 21 in a large majority. In Arunachal Pradesh, which is even more remote, close to the China border, the prevalence of diabetes is around 5%, and this was in the year 2012, with a 13% prevalence of impaired fasting glycemia as well. And as you can see over here, the individuals are very lean. Generally, their median BMI was around 20 to 21 or so. An ongoing study is looking at tribal areas across the country, and we have adopted the state of Meghalaya, which is on the Bangladesh border. And once again, we are dealing with a relatively lean population. Having said that, it appears that the prevalence of diabetes over here is lower, but there is a significant quantum of hypertension in this group. So let's talk a bit about the Barker hypothesis, which for this audience is nothing new. What Barker described about 3 decades back is that individuals who are born low birth weight have an increased propensity for developing hypertension, diabetes, and obesity a couple of decades later. The fetus develops a phenotype that has an advantage for survival in the presence of adverse nutritional situations. But in situations where there's an exogenous nutritional supply which is excessive, it may be a large disadvantage in the adult phase of these individuals. So low birth weight is a problem and still is a problem in India. At one point of time, it used to be around 26%. A state like Tamil Nadu, about a decade back, had percentages with excess of around 18%. It's come down significantly in the last decade. But what has been shown, and Dr. Yagnik has also spoken about this over many years, the last 3 decades, we know that the Indian babies are shorter, lighter, and have less muscle mass, but have a adiposity. This was a study which was published more recently, looking at the Pune maternal nutrition study, a study which was done between Dr. Yagnik and also in collaboration with the Southampton group. And at the age of 18 years, 37% of men and 20% of women had pre-diabetes. 48% had a BMI of less than 18.5 kg per meter square, and this is largely a rural cohort. Mothers of hypoglycemic individuals had higher glucose levels during pregnancy. Insulin sensitivity declined with age, and those with glucose intolerance had a progressive decline in insulin secretion. And at the highest quintile of fasting glucose, which was measured at the ages of 5 and 12, there was a 2.5 to 4 time risk of glucose intolerance at the age of 80. So there is, I guess it's time to say whether it's called a hypothesis. It's probably much more than that. It is probably the Barker phenomenon rather than the Barker hypothesis at this point of time, because we do know that there is substantial evidence now to prove that this happens. A little bit about our work over the last 50 years. We're very fortunate. Biostatistician 50 years ago had started the VELLORE birth cohort, and screening is done every 5 to 10 years. The seventh phase of screening has been completed, and I have had the fortune of working with Carolyn Fall from Southampton, my good colleague Senthil Vasan, who trained here at CMC and subsequently is now in the United Kingdom, and Frederick Carpe from Oxford, who helped out with the last two screening processes. This has about 2,000 active subjects aged 47 to 52 at this point of time. Let's look at the comparison between phase 5 and phase 6. And you can see this massive exponential increase in non-communicable disease. And what you can also see over here is that there is hardly a difference between the urban and the rural. This blunting, even though the density of population has really not increased that much in rural areas, there's a blunting in terms of the discrimination between the rural and the urban groups. You can see quite clearly here that the prevalence of diabetes is pretty massive in rural VELLORE and almost equals that of urban VELLORE. In women too, this is a massive issue in terms of the increase in prevalence as well. Now, in this particular group, which is a little different from the Pune cohort, at this point of time, in the last 5 to 6 years, lean diabetes is largely isolated. It's not that much of a problem at this point of time. If you look at the initial publications from the VELLORE birth cohort from the late 1990s and the early 2000s, there was a significant number of patients with impaired glucose tolerance and diabetes who were with low BMI in the ranges of around 18 to around 21 or so. But that does not seem to be the case now, wherein obesity has actually become a huge problem, wherein almost 50% of women are having BMIs more than 25 in some of the urban areas. Flirting with the thrifty phenotype, we are looking at the thrifty gene hypothesis. And this was also done with collaborative work with Karolinska as well as Oxford. We have looked at several single nucleotide polymorphisms. And over here, we looked at the ADCY single nucleotide polymorphism, which is associated with impaired glucose tolerance and diabetes at the age of 28 years. But it is not associated with a low birth weight in our population as opposed to the European population. Here, we have looked at the FTO and the MC4R single nucleotide polymorphisms, and we found this association that FTO has an impact on obesity in adults. And in a further study, we've had an impact on the waist circumference in children. MC4R had a significant impact on the height, but not on the weight in this particular study. This is another interesting phenomenon that we have seen, and people kept asking me, I've always seen that my glucose after my meal is lower than my fasting glucose. So I would have thought that this is associated with hyperinsulinemia and was an unhealthy phenotype. But indeed, what was found when we investigated this further, that it was associated with a leaner body habitus and a better insulin secretion. It's an area which actually demands a lot more research, which we should be looking at in future. So I'll now switch to from the Barker hypothesis and the epidemiology of our region to the experiments that we have done in connection with the pathophysiological impact of the Barker hypothesis in India. This was done in collaboration with the Copenhagen University, and I'd like to thank my key collaborators who were involved, Professor Hibberg, Professor in International Health, Dr. Alan Moore and Louis Brunet, who were actively involved in this. At the time when we initially started this work about 15 years ago, we were naive towards these experiments. In fact, our team, including for training to Copenhagen, acquired these skills, and now it's become part and parcel of our departmental activity in terms of some of the research that we do. So our questions are very clear. How does low birth weight influence body composition, energy expenditure, insulin sensitivity and arterial blood pressure in the Dravidian population in early adulthood? Are the changes that occur in the rural population in India likely to be less dependent on environmental influence? There have been a number of studies which are done by many colleagues, good ones which have been done, but they're largely used empirical indices like HOMA-IR and skin fold thickness to look at adiposity. So we thought we'd go a step further. We had the fortune of having another birth cohort started by our community health head of department, Dr. Abraham, way back in the late 1980s. 60 normal birth weight and 60 low birth weight individuals. We've actually blinded. They were screened by our community health professor, Dr. Venkat, who brought them over to the hospital. And we, in fact, did not know their birth weights when they were brought to us. And they had completed puberty. We looked at exclusively a male group over here, healthy, physically active males. I should mention once again that the median BMI at this point of time between the age of 18 to 22, about 10 years ago, was only 19.5 kg per. But they were young, fit, muscular individuals. So this is what we did: hyperinsulinic euglycemic clamps, indirect calorimetry. We looked at the total energy expenditure, measuring the heart rate to active heart, and NMR spectroscopy to look at the micro quantities of fat in the liver and in the muscle. Now, very briefly, I'll just highlight these findings. There were a lot of negative findings in the study. Very interestingly, the indirect calorimetry was negative and did not show any significant changes. They were shorter, lighter, had a reduced muscle mass, and a trend towards reduced bone mineral content. They had an elevated diastolic blood pressure. And one thing which is quite intriguing is that they had a reduced dietary intake of protein if they were born low growth. It's a kind of a learned behavior which is persistent into their adulthood. They did not show evidence of difference in terms of insulin sensitivity. The M value on the clamp did not show a decline. It was comparable to the normal birth weight, and the lack of environmental influence might have been the reason for this. At that time, about 10 or 15 years ago, it appears that the rural area was reasonably pristine. Their lifestyle was reasonably good. I can't say the same at this point of time, 15 years later. We have to look at these subjects and start doing the same sort of studies once again in a longitudinal fashion. There was no diabetes in any subject below the age of 25 years in the cohort in the low birth weight group. Now, let me tell you that rural Tamil Nadu for the last 20 years, at least the region where we are living in, is perhaps, I would say, the word free of gross poverty, in the sense that there are the basic needs which are there. They have everything, and they're not malnourished in terms of not being able to acquire food at any point of time. This was the dietary recall which I mentioned to you, that there were significant differences in protein intake and the percentage of energy from protein, which was also calculated over here. The next thing that we did is we gave all these young men a bicycle and made them exercise for 45 days. And this was done in collaboration with Cambridge to analyze their physical activity indices. We had some problems with using the ActiHeart in this extremely humid weather. But let me tell you, with this longitudinal study, which we did over here, and we, of course, had the Botnian clamp, the IVGGT, and then subsequently repeat GGT 45 days later, we found that the low birth weight group had a significant increase in muscle mass. There was a difference in fat-free mass to body weight ratio, and there was a trend towards an increase in basal metabolic rate in the low birth weight group. There have been very few studies which actually looked at this in terms of trying to see whether there is an improvement in the indices in terms of energy expenditure or body composition. And the good thing is that the low birth weight people do respond to exercise. Now, we didn't look at very low birth weight. We looked at low birth weight, which in our definition was a weight of around 2.5 kilograms at birth and more than 2 kilograms over here. We did not look at the very low birth weight group in our studies. We also did NMR spectroscopic studies over here, and Roshan was instrumental in setting up these experiments in CMC VELLORE. Very briefly, the young and lean men from South India born with low birth weight had low ectopic fat storage in the liver and the muscle, not very different from the normal birth weight individuals. And the fat in the liver or the muscle was not related to insulin resistance. Quite in contrast to the NMR spectroscopy studies, which have been done in obese individuals, some who have been done by Dr. Anup Mishra in the north of India, and of course a number of studies which have looked at Asian Indians living in the United States. That's a group which is significantly much more well endowed in terms of their fat content in their body, very different from this particular group. So once again, summarizing over here, we looked at the EMCL and the IMCL, and the IMCL content showed no difference irrespective of birth weight, probably due to a reasonable peripheral sensitivity that was seen. The hepatic fat content was undetectable in a significant proportion of subjects. And this phenomenon was actually previously reported only in Afro-American subjects, not in Caucasian subjects prior to this. Right. We have looked at a number of other indices because we're talking about being cost effective and versus the clamp. Looked at other markers like the lab product, which we find pretty good, the triglyceride glucose ratio, fasting insulin versus the clamp, waist height ratio of insulin resistance, and bioimpedance analysis versus the DEXA for measuring fat, and found them all reasonably good when you want to use it in a low-cost model in the periphery. Now I'll come to this condition called fibrocalcific pancreatic diabetes, a condition which still exists in India. 33-year-old gentleman, laborer, upper abdominal pain radiating to the back since 1 year. Coming back to the case I presented to you initially, significant weight loss, diabetes, initially on oral anti-diabetic agents, subsequently requiring insulin, no history of alcohol ingestion. BMI of 20.5, no nutritional deficiencies, and no significant findings on examination. So because he had weight loss, an X-ray was done, and presumably initially to look for tuberculosis. But what it did show was this large calcification in the upper part of the abdomen, the region of the pancreas. And the stool elastase levels were low. Now, what is expected when you have these fibrotic pancreas is that they may have a significant steatorrhea and they may complain of oily stools. But many of them adapt to their diet and they actually start taking a less fatty diet. And so they do not experience steatorrhea in due course. The CT abdomen confirmed the finding of dilated ducts, large calcification, and the MRI unfortunately showed another finding, which showed a significant mass in the head of the pancreas. Prone for malignancies as well. If they live up to the age of 50, there is a 40% chance of these individuals developing malignancy. They are more common in males and they are essentially non-alcoholic. You can see the marker here for pancreatic malignancy is significantly elevated, and he had an adenocarcinoma. Not all of them are that unfortunate, but let me tell you that could be one of the sequelae which could occur. One of the nice reviews done way back with Dr. Mohan and Dr. Yagnik about 2.5 decades back is still really worth reading. 70% male, lean BMI, no signs of insulin resistance, and they do not develop ketoacidosis. Their C-peptide levels are low, and the duct dilatation is very prominent with intraductal calcification, unlike the parenchymal calcification seen in other forms of pancreatitis. So this disorder, in fact, the pre-diabetic disorder is called tropical pancreatitis. Though no one has actually done a longitudinal study and showing the conversion from one to the other, we presume that the pre-diabetic state is tropical pancreatitis, pancreatic diabetes, and is seen largely in tropical areas of the world. We have looked at other aspects of this, and we have looked at indirect calorimetry and energy expenditure in this condition. And interestingly, they have a high energy expenditure in this situation. We presume that this might be due to the fact, and I'll come to that later. Perhaps I will not disclose a little secret, which will come a little later, as to why the energy expenditure is high in these individuals. So, because of the uncontrolled diabetes, the presence of steatoria and the high energy expenditure, their calorie requirements are sometimes massive. 2,500, 3,000 calories per day. If they really need to build up their bodies, they need to do that. We have looked at their bone health, and we have found that they do have osteoporosis indeed, but this is related to the steatoria and not due to the vitamin D deficiency. They have a high prevalence of autonomic dysfunction, almost 60%. It's a combination of nutrient deficiency as well as uncontrolled diabetes. The micronutrient deficiency is common from their dietary recall, and it's something which we are thinking of looking at in greater detail by looking at the trace elements over here. And very often in peripheral areas, the opposite sometimes happens. Individuals as a pancreatic disorder with steatoria, and they in fact have uncontrolled diabetes or other forms which may be causing this. So from a traditional perspective, secondary diabetes with prominent insulin secretion defect with a fibrotic pancreas should have a glucagon deficiency, lean BMI with a reduced body fat content. So our research question here is, does insulin resistance contribute to FCPD, fibrocalcic pancreatic diabetes? Are insulin and glucagon secretion defects ubiquitous in FCPD? So this is a very nice study, once again done by Dr. Yagnik almost 3 decades back, and very exquisite, the biochemistry that has been pursued over here. Lower non-esterified fatty acid levels were seen, lower beta hydroxybutyrate levels, and increased glucagon levels. Now, the first two might explain as to why they don't have ketosis, but the last one does not. So the glucagon levels are actually elevated in that study. And why should that happen when you have such a fibrotic pancreas which duct dilatation? I'd expect the alpha cells to be knocked out. So this is what we endeavored to do in our patients with fibrocalcic pancreatitis. We did body composition studies, and several other studies as well. And what we found over here, of course, there was a significant deficiency of insulin. We had controls with type 1 and type 2 diabetes as well in the study. The glucagon levels, intriguingly, were elevated. You have over here type 1, you have the normal subjects, but you have the glucagon levels which are actually elevated in these subjects. Now, why do they have this? So we did further experiments. We also looked at the relationship of hypoglycemia unawareness, because a lot of these patients do have hypoglycemia unawareness because historically, sometimes from poor socioeconomic background, and due to poor control, they have autonomic dysfunction, etc. So this is a study which we did, studied a large number of patients with fibrocalcic pancreatic diabetes and calculated the hypoglycemia unawareness index. We divided them to a hypoglycemia unaware group and an aware group, and they all underwent the autonomic function test. We took a subgroup and did mixed meal challenge tests and measured their glucagon levels. And what we found again, we replicated the same findings. The C-peptide levels were low, as expected, but the glucagon levels were elevated. And the elevation in glucagon levels was seen in those who had hypoglycemia awareness. Those with unawareness had low glucagon levels. So we have replicated again what Dr. Yagnik had shown almost 30 years ago, that the glucagon levels were high, but they were suppressed, and indicating that you're more prone for hypoglycemia once the glucagon levels drop. So once again, the mystery behind this whole thing, why are the glucagon levels elevated? So the glucagon levels, as you can see here, once again, correlated very significantly with the area under the curve, with hypoglycemia, negatively with hypoglycemia unawareness. And the MACE, as you can see here, also was negatively correlated with the glucose excursions. Post-meal hypoglycemia correlated with the glucagon levels. So why should hyperglucagonemia occur in such a profoundly atrophic calcified pancreas? As beta cell insufficiency is present, would not one expect alpha cell insufficiency? So we looked at the incretin axis next. The C-peptides were low, as you can see over here. In the controls, we measured pancreatic polypeptide, and you can see over here that the pancreatic also low. We measured GIP levels, and what we did find over here is that the GIP levels were also suppressed. So the K cells are also defective in their production of GIP. And then we measured the glucagon and found it elevated. And you can see over here we did the intravenous glucose tolerance as well as the oral glucose tolerance. And you can see the OGTT provoked rise in glucagon levels and not the intravenous glucose tolerance test. So what does that mean? We went further and we looked at GLP-1 and found it elevated, and oxyntomodulin also found it elevated. So if you put 2 and 2 together, it tells you that perhaps the glucagon is actually coming from the intestine. This is our presumption. We haven't proven it, but scientifically, this seems to correlate. We plotted the curves of the glucagon versus the GLP-1, and we found them elevated. And I think I'd like to actually credit this exquisite work. Of course, a lot of the support from the Albert Einstein Medical College and Hawkins, and of course my very good colleague Riddhi Das Gupta, who has done a wonderful job with FCPD as well, and is currently now at Cambridge. So the closed oral glucose tolerance test and glucagon levels in FCPD show significant correlations. So in the presence of gross pancreatic atrophy, where is the source of glucagon? Is it pancreatic or is it extrapancreatic? If it is extrapancreatic, is it from the gut? And is there an interplay between incretin and glucagon axes in FCPD? So, well, this consortium, which has of course done a lot of work in connection with incretins and glucagon, showed that there's probable evidence of extrapancreatic glucagon secretion in man. And what we believe, therefore, is that the proconvertase 2 enzyme is active when you're talking about glucagon secretion from the alpha cells. But when you're talking about production of incretins and glucagon also from the gut, it is the proconvertase 1/3 which is responsible for production of glucagon from the gut. Now, of course, we need to prove this, and this will need some time and a lot of ethical issues as to whether we can biopsy the gut to prove this diagnosis. That's some way off, and we are thinking about it. So, FCPD has elevated glucagon secretion, elevated GLP-1 secretion, elevated oxyntomodulin, suppressed C-peptide, and suppressed pancreatic polypeptide secretion. This was a collaborative effort which was done with the Sanjay Gandhi Institute. Dr. Ish Bhatia spearheaded this study, looking at the prevalence of young onset diabetes. Quite naturally, type 1 was the commonest. And interestingly, in that group, there were young obese individuals, and type 2 was the second commonest thing. But the third important thing, a forgotten disorder, is FCPD. And I think this should be looked at in all tropical populations in India, Africa, because very often a simple ultrasound of the abdomen is not being done. And many of them did not have abdominal symptoms or steatorrhea at all. And of course, in this, we looked at the genetics as well, and we found that genetic conditions are the next common thing. Now I'm going to talk about monothetic disorders and lean diabetes. A girl diagnosed to have diabetes on routine testing, thrice daily insulin, recurrent history of renal stones with chronic renal failure from 12 years of age, and baseline creatinine was elevated. So renal failure was a presenting symptom. Cyclically low abdominal pain, not attained menarche. So BMI was 21.2, and she had reasonable pubertal development. So what's your diagnosis? Diabetes with amenorrhea. Is it Turner syndrome? The FSH and LH look good. So what are we dealing with? So an ultrasound showed something and was further confirmed with an MRI. And you can see over here, there's a bicornuate uterus. The MRI of the abdomen shows an atrophic pancreas. And basically, and there's no calcification, there's no pancreatitis. This is a MODY5. So we confirm this with next generation sequencing. And this disorder, of course, has a number of other associated uh, uh, parts of the syndrome, wherein you can have renal cysts, which may be a very prominent feature, and absent vas difference in males. 16-year-old boy came with progressive weight loss, osmotic symptoms, high glucose levels, immensely low BMI, 11.3 kg per meter squared, and bilateral immature cataracts. His autoimmune workup was negative, C-peptides were low, fat in the stool, and imaging showed a mildly atrophic pancreas. So we did NGS and we found that this boy also had a MODY5. So as you can see, the presentation of MODY5 can be quite vast and varied. 29-year-old lady with diabetes in the first pregnancy had oily stools, increased frequency of stools, abdominal pain, ultrasound was reported as chronic gastric pancreatitis, had exocrine insufficiency. And what you can see is that there's an atrophic pancreas, as well as you can see the prominent splenic vein, and there's a lot of fat. We had a few pancreatic calcification, nothing very prominent. So this ended up being a carboxy ethyl lipase mutation. Now, this is not, this histopathology slide is actually taken from this wonderful article, which has looked at the other forms of genetic causes for pancreatic atrophy. These are disorders which who we see a lot of FCPD, should be aware that there are other conditions where you can get an atrophic pancreas, which is not fibrocalcific pancreatic diabetes. Coming back to our work on MODY, and bright scientist Aaron set up the NGS about a decade back and has done work in connection with not just MODY and insulin resistance genes, but a number of other endocrine disorders as far as NGS is concerned. We have found that certain forms of variants are more common in our Indian population. And in fact, we looked at this other interesting question. We have a number of women with gestation diabetes who have BMIs of barely 21. And in the first trimester of pregnancy or the second trimester, why should they get gestation diabetes? They are hardly 25 years or maybe less than that of age. And we did find very interestingly that there were a number of individuals who had variants, which might in part represent the reason why they were developing gestational diabetes. Of course, this is a screening bias because as endocrinologists, we get the most difficult to control gestational diabetes or require insulin. I'm not saying that we get percentages like this in the general population of gestational diabetes. So looking at the work which has been done by Mohan in connection with monogenic diabetes and our work, there are certain forms which are actually more common in the Indian population. The GCK mutation is not as common in our population when compared to what is seen in the European populations. And there's a whole host of others which can be seen in our population as well. And it's important to identify this because having a young man or child wherein you can actually manage them pretty well with oral anti-diabetic agents in a good proportion is something. But you also need to remember that forms like MODY5, etc., may require insulin, particularly if they have beta cell deficiency, which is profound, and an atrophic pancreas. So I'm just reflecting once again on the BMIs of this. You do have patients who have MODY or monogenic beta cell dysfunction, wherein the BMIs can be actually as low as 18 over here. So this is something which one should bear in mind and remember. We have actually tried to look at the BMIs of individuals and the standard deviations, as you can see over here, can be quite varied. So you can get lean individuals with, or rather ultra lean individuals, BMIs less than 20 in individuals who have OD as well. And so it should be thought about. When you think about an atrophic pancreas, there are other conditions, and this is something which Aaron is working at with the passion, looking at the differential diagnosis of fibrocalcific pancreatic diabetes and looking at this panel wherein we can pick up other conditions where you can have a atrophic pancreas, even the mitochondrial mutations which can cause a pancreatitis. 38-year-old girl, lady rather, diagnosed with diabetes at 19 years of age, initially diagnosed as type 1, but like any young lady, she skipped her insulin periodically because she thought, what the heck? I mean, I want to be better. I don't need insulin. And even when she skipped insulin, she never developed ketoacidosis. But to control her sugar, she needed huge doses of insulin, almost 400 units per day. She had a markedly reduced subcutaneous fat and had these prominent veins, as you can see over here. And her triglycerides were elevated. Her C-peptides were also borderline high, and she had a proteinuria. So this lady has an abnormal distribution of fat, and you can see the DEXA scan, which has been performed over here, that this reduction in fat and also the upper part of the body has this distribution of fat, and this is a partial lipodystrophy and it's laminin mutation that this lady has. Here is another patient over here with complete lipodystrophy with the PAT2 mutation. So, like cause for lean diabetes, they can be extremely lean, very low BMIs, but it's a much rarer condition than any of the other conditions which I've actually talked to you about. And of course, HIV is another condition wherein our population now, because we have a good ART program in India, a lot of individuals who are having on antiretroviral therapy are actually living longer, and we should be aware that they're becoming more prone for lipodystrophy and diabetes. 20-year-old gentleman with polyuria polyphagia presenting with on basal bolus insulin, frequent micturition, diagnosed as type 1 diabetes, has evidence of a high sodium as in addition, and the antibody workup and ultrasound were negative. Has a dilute urine indicating that he has diabetes insipidus. And the sister also had something which is diagnosed as type 1, but also had deafness, oral intake, and passed on at the age of 26 years. So we did a screening and we found that there was a mutation for Wolfram syndrome, for something which was diagnosed as type 1 for a very long period of time. It's published recently in the Journal of Clinical Endocrinology and Metabolism. And you can see over here that this condition, of course, can have a number of neurological symptoms in addition, but many of these individuals can present with a syndrome who may just require insulin and may not have anything very much other than maybe subtle deafness in a subgroup. So this is the full syndrome of Wolfram syndrome, but you can get a much milder disorder, which we should look at as a differential diagnosis for young onset diabetes, which could be inherited. Aaron had done a microsatellite study and also picked up of the first founder mutation in Wolfram's like syndrome. So I will talk finally about this condition called atypical low BMI diabetes and its pathophysiology. So this condition was, as mentioned, described way back in the 1960s and entered the WHO classification in the 1980s, but was taken off because of lack of substantiation. Severe diabetes, or inverted commas, glucose more than 200, very lean, BMI is less than 18, ketosis resistant, and invariably belong to poor socioeconomic status, requiring insulin more than 60 units a day, described by the pioneers of this disorder as requiring a high insulin and lack of any other cause for diabetes, no antibodies, normal imaging of the pancreas. And here is a young man from the fields close to VELLORE, the rural area. In fact, they're not particularly common in this region in South India, in Tamil Nadu. So we did an extensive study, and this is spearheaded by Meredith because she had seen a lot of these patients in Africa during her travels over there. And this is how we screened them. We ruled out other conditions. We did an extensive genetic testing as well, and we ruled out other conditions as well. So we compared them with type 1, type 2 lean controls and overweight controls. We did the elaborate pancreatic clamps wherein one gives somatostatin, growth hormone, and glucagon. And we also did deuterated glucose measurements to look at the hepatic glucose disposal in addition, and NMR spectroscopy. And what we found is they did have insulin deficiency, but it is not as profound as type 1 diabetes. They had, in addition, hepatic glucose output, which was significantly lower than that of type 2 diabetes. And therefore, this condition is not, which some people tend to call lean type 2 diabetes. It's not lean type 2 diabetes. They have lowered hepatic glucose output. They have a low beta cell secretion. And so we're dealing with something quite different over here, and we've ruled out other conditions. Moreover, 50% of them seem to respond to sulfonylureas, DPP4s. We need to characterize this better because the numbers we have studied are small, but a good number do not require insulin. They had dietary preferences indicating higher carbohydrate intake, significantly reduced protein intake, and decreased fat intake as well. What about the incretin axis? And this is yet unpublished data, and this is quite fascinating. What we did find is that the glucagon levels, well, they maintain a reasonably normal pattern, but the GIP and the GLP-1 levels were actually low, indicating that the enteroendocrine cells are probably dysfunctional. Now, why is this happening? I can only guess, and we can discuss. We have gone into a lot of debates as to whether this could be a form of severe insulin deficient diabetes, a variant of type 2. Well, it's not. Look at the body composition, look at the beta cell secretion, look at the hepatic glucose output. It is not that. Their BMIs are much lower than what has been reported in SIDD. Even the Indian SIDD, reported by Mohan, has a median BMI of around 24.9. Our patients had BMIs which are less than 19. Here is another study which has looked at comprehensively right across the country at SIDD, and you can see over here the BMIs are much higher than our called protein deficient diabetes. So I'm redefining the condition, and I'm saying that, well, they do not have to have very high sugars, and they do not have to have very high insulin. But the other parts of the categorization still exist. Should we change the name? We don't know the cause. We don't know what we're dealing with. Shall we call it something else? Should we rename it as ultra lean diabetes rather than malnutrition modulated diabetes? The coincidence is there. There is, if you look at the global map for malnutrition and if you look at the low birth weight association, it's there in India. But I think we shouldn't be biased in saying it is due to malnutrition. It seems to coincide. And there have been histopathological studies done in rats, which have shown that there are these phenomena of microislets in rats in malnourished animals. So this is just food for thought. So when we have a lean diabetes patient, we need to evaluate them thoroughly, detailed history, pedigree chart, physical examination, C-peptide levels, an imaging of the abdomen, body composition studies, next generation sequencing related testing, and of course, other supplementary genetic tests if required. We should think in our Indian or rather Asian setting of fibrocalcific pancreatic, important differential for type 1 or slowly evolving immune-mediated diabetes, monogenic disorders of beta cell secretion, some forms, Wolfram's-like syndrome, and of course, finally, this extremely intriguing condition of ultra-lean diabetes. So with that, I would like to conclude. I'd like to thank all our team members at VELLORE for the wonderful contributions. There's a lot more people than I can actually cope with in terms of saying thank you to. Big thank you for everyone on the team and international collaborators across the board. Meredith Hawkins, who we've been working with very closely for the last decade, Alan and team from the Copenhagen University, and the team from Oxford, Southampton, and other parts of the globe. Thank you for your patient listening.
Thank you, Nihal. That was a very nice presentation. So if you can stop sharing, that'll be helpful. So we have about 4 or 5 minutes for questions. Let me open up for questions. Meredith, you have your hand up.
Thank you, Venkat. As a matter of fact, I was adjusting my video, but I would like to say that was a beautiful talk for Professor Nihal. I was actually intrigued as I was watching when it came to the lean women. that you were describing, that there was we, of course, with the ultra-lean diabetes that I think you described so well, we were dealing with a scenario which afflicts mainly males. And of course, we only studied males. But I was very intrigued when you had very lean women. It was quite a different phenotype, and they were more insulin resistant, et cetera. There was also the relationship of pregnancy and so on. But I was curious to know if you felt that hormones are playing a role, because for all of us who are dealing with, for instance, diabetes in Africa among very lean individuals, we tend to realize that it's in men that they tend to develop the diabetes, this very thin type of diabetes. But I'd just love your thoughts about gender and how that might be playing a role.
Meredith, is that question to me or is it to Venkat?
I guess anyone that wants to answer it. Maybe it's unanswerable.
Yeah.
It's a rhetorical question, but I think Nihal should answer it.
Yeah. So, okay, to be very clear, and the reason why we have never done these studies, elaborate studies in women, is multiple. In rural women, the hemoglobins are touching 10 to 10.5. And when you do hyperinsulinic euglycemic clamps, you tend to take a lot of blood. The issue of the challenge of the menstrual cycle and the hormonal effects that they have, the optimal time of doing it after the menstrual period is a very big challenge. And the third challenge was, of course, getting these young women to come from a rural area would have always been a major challenge. So there were ethical as well as social issues in actually doing this. So to be very honest, it would be actually quite difficult for me to guess as to what would be the actual physiology which is happening over here. I think the proof in actually looking at it is eating the pudding to try and see what happens. That would be my way of thinking about it. But having said that, yes, we do need to do these studies in women in addition.
Guillermo, Dr. Perez.
Thank you so much, Professor Thomas, for your amazing amount of research and for your lecture today. I was impressed with the increased rate of diabetes, but not in pre-diabetes in India. The findings that have been reported in other countries. So if we believe that diabetes is progressive disease going from normal impaired glucose tolerance to diabetes, I would have expected to have an increased rate of pre-diabetes as well as diabetes. Can you comment on that? And the second part of that question would be, have you ever studied pre-diabetes in lean individuals in India?
Thank you, Dr. Perez. The fact is, there is a fairly significant proportion of pre-diabetes. And I guess one of the formifrostes of pre-diabetes that we see a lot is gestation diabetes in women. And there's plenty of that we have in our Indian population. I think when I started my talk, I projected what Dr. Yarjanik had actually done in the Pune maternal nutrition cohort. And he could probably elaborate more. But we do have, in fact, he did have a fairly significant amount of pre-diabetes in very lean individuals. And that was perhaps a decade and a half back. And yes, there is a good amount of pre-diabetes that we see. The other thing is, of course, I think if I remember the consolidated IDF data, that we have a lot more impaired fasting glycemia in our population, more than frank impaired glucose tolerance. Venkat, you would also like to perhaps comment on that.
Yeah, absolutely. When you look at the epidemiology of prediabetes in South Asians, a much higher proportion have impaired fasting glucose and a very low proportion, relatively lower proportion, impaired glucose tolerance. I mean, again, that gets back to why, because the determinants of fasting glucose are beta cell function and hepatic insulin resistance. I think that's been shown in clamp studies. So that's something to keep in mind. I just want to conclude, I have a call to run to Nihal, so I'm going to let you all talk and ask questions. I'm going to leave the call, but I just want to make one comment for us all to think. Again, by studying these rather rare variants, you've clearly beginning to point to certain important physiological insights. My larger question is, from those insights, is there something generalizable for the more common variants of type 2 diabetes in South Asian populations? So let me leave that question. You can answer it. I'll catch up with you later. So Mark, can you conclude take care of the rest of the session for me? Thank you.
Yes.
Bye-bye. See you, Nihal. Apologies.
Thank you, Venkat. I think Dr. Yajnik has raised his hand.
Hello, Nihal. That was wonderful. So thank you for such an elaborate investigation. And to take Meredith's sort of question about pre-diabetes in thin women, the paper which you quoted, the one we published last year in Diabetes Care in the Pune Maternal Nutrition Study, at 18 years of age, 30% of these young individuals with an average BMI of 19 had pre-diabetes. Substantial proportion of that was IFG. IFG was more common in boys than girls. So in boys, almost 40% had pre-diabetes. In girls, 20%. And interestingly, out of the pre-diabetic boys and girls, 1 in 3 boys and 2 out of 3 girls had a BMI less than 18.5. So 2/3 of the pre-diabetes. And I have debated this with Ralph DeFronzo, and he shows all the pre-diabetes slides, which I think are heavily confounded by obesity in the Americans. And I tried to sell to him that we have got what we call pure pre-diabetes, which is not confounded or contaminated by high BMI. And if we trace their glucose tolerance back at 12 years of age and 6 years of age, what we find in girls is that it's a pure beta cell lack of response to prevailing insulin resistance, which we call low disposition index, present from as early as 6 years of age, then 12 years, and then 18. And now we have one more point to add, because out of these 350 girls, 200 married and became pregnant. And therefore, we are able to trace their pregnancy glycemia back to their young age. And what we show is fasting glucose in pregnancy is traceable back to 6 years, 12 years, and 18 years. So to me, studying all these conditions in adults is like studying an end stage. We have heavy reverse causality added to the cross-sectional studies. Unless you have prospective measurements like in VELLORE cohort or Pune cohort, it's difficult to deconvolute the real natural pathophysiology of the condition. And we are very unduly influenced by reports from Western literature where obesity is the driver of pre-diabetes and diabetes in the young. And we see that predominantly in the undernourished. So I think these are tale of two different worlds. And in our cohort, we traced it back to linear growth failure in utero. So they were stunted and had smaller head circumference. And interestingly, what we have not published, we had measured liver and kidney growth in utero in the 3rd trimester. And future prediabetes is very strongly predicted by poor liver growth in the 3rd trimester, coupled with larger liver size at 18 years without any fatty infiltration. So it's the mismatch of liver growth in utero and subsequently, which are strongly associated with prediabetes. And I suspect similar thing happens to pancreas in the 3rd trimester, though we haven't found ultrasound technique to measure pancreatic growth in utero. Pancreas measurements are very difficult. And we replicated that in a 50 generation undernutrition rat model, which we published in 2015. And that 50 generation undernutrition model is called Thrifty Jerry. Name was suggested by my younger son. And Anand Hardikar, who was my PhD student and now he is professor in Sydney, did brilliant epigenetic work in the beta cells in that model. And we shown patterns of epigenetic changes in the beta cells with chronic undernutrition, which do not erase by 2 generations of normal feeding, but 2 generations of normal feeding in them makes them very fat and obese and diabetic. So we have an animal model to show that, a life course intergenerational undernutrition model.
Thank you, Dr.
That
Yamnika.
was my observation.
In fact, I think the analogy, what you described about underdeveloped organs, the liver fat is extremely low, which is another feature which you have noticed in this condition. Dr. Yogesh Jain, you have your hand is raised.
Yeah. Thank you, sir, for this, wonderful discussion that you did and the question that I followed. I want to say, as a physician practicing in central India, among the Adivasis in Chhattisgarh, that the pattern that you mentioned last, the protein deficient one, the ultra lean diabetes type, is what we see as a predominant form of diabetes. When we even count all the type 1, type 2, and this thing as a predominant type, 70% of the people that we see have BMIs lower than 23, and 40% of all people with diabetes have a BMI lower than 18.5. And I believe, and it's probably the chronic undernutrition, even though the BMI rates in our, even though the low birth rates in our country, in our area, is only 16%. That it is probably the bad chronic undernutrition, along with the carbohydrate excess due to the rice program that we have, which I feel. So my specific question to you is: do you feel that the excess of cereals, the cereal security that the program that the country is offering, is one of the reasons for increasing the risk of getting diabetes of the type, the protein deficient type that we see, which is very similar to the type of diabetes I've seen in Ethiopian people, and a little different from the other types of lean diabetes that you mentioned? Over.
Thanks for that. And it's a very good question. In fact, I was just telling Meredith, what if we patients with amino acids change the kind of meal and see whether their beta cell secretion actually improves? I mean, I don't know whether damage is permanent or whether it is temporary. So that's a question which is worth asking and trying to answer, whether we should be using stable isotopes with amino acids and seeing whether the insulin production actually improves. That perhaps would be a good question. I don't know the answer to the question until we actually try to figure it out, because this is all a longitudinal effect over many years. You know, fibrocalcific pancreatic diabetes disappeared from Kerala. I mean, not disappeared, but drastically came down. It was the home of fibrocalcific pancreatic diabetes many years ago. So what is it in the environment which changes in certain disorders is difficult to answer. Dr. Umperes, your hand is raised again? Sorry.
I believe it.
Very quick question. You know, a recent study from Today in the New England Journal of Medicine says that the rate of complications in young adults with diabetes is markedly increased, like 50% of young adolescent young adults 10 years later have microvascular complications. Can you comment on the rate of complications in your lean individuals in India?
Yeah, so the answer is I don't know. The reason is we are good at doing these physiological studies with Meredith's help on young individuals, but we really had to scrape the bottom of the barrel to get these subjects. It was very difficult to get these subjects in Tamil Nadu. I think Yogesh is the person who can actually answer that question much better than me, because he sees a lot of it, and he's one of those rare physicians, scientists working in the back of Beyond, someone who's doing good work over there. Yogesh, are you there? Oh, I think he's moved off. Right.
Well, thank you so much.
Okay. Professor Thomas, do you have maybe 5 minutes more? We have a couple of questions in the chat, and then we can wrap up. There was one, why is FCPD ketosis resistant in spite of high glucagon? And can it be due to lower free fatty acid level?
Yeah, So could FCPD be due to low free fatty acid level? Is that the point?
I believe that.
Sorry,
yeah.
was it? Yeah.
Yeah.
No, I don't link the two together. Meredith, what would be your thoughts on that?
And that
I'm
was
not sure how.
Koshal Shed.
Free fatty acids can, of course, perhaps be partly responsible for the fact that ketosis is not common in these individuals. That's about it. But I'm not certain about the lack of beta cell responsiveness or the beta cell dysfunction, which I can't think of that. That wouldn't be a reason. In fact, I'd expect it to be the other way around. So,
Yes, I would agree. So in other words, not causative, but I would expect that the low insulin levels in these subjects would result in higher fatty acid levels as a consequence. So I'm totally in agreement with you.
And then we had another question. We'll just add, how can we better classify diabetes phenotypes to inform management decisions at the bedside?
okay, that's a massive question if you ask me.
Philosophical question.
But but it's very real. I think it's important. I think once again, it's looking at what is common in your part of the world where you work, and then trying to develop your algorithm. And that's what we are trying to do over here. I mean, I can India or the part of India where I'm from, I put fibrocalcic pancreatic diabetes quite high up as something which is being missed. And then I would put some forms of MODIs also which are being missed. And then of course, we also have this young adult group who's becoming increasingly obese and sedentary, and you have a lot of young type 2 also coming into the picture, which of course we didn't talk about today at all, but that is also there. So the algorithm and the should be defined for the region of the world that you're looking at. It can be very different here and be totally different in some other part of the world as well. There's a very interesting point by Shashikala. Are you still there? You said that you have identified glucagon staining in the pancreas in patients with fibrocalcic pancreatic diabetes. She's not there, but that is interesting because I think they perhaps do a lot of surgeries on chronic pancreatitis in the Asian Institute of Gastroenterology in Hyderabad. And so that's looked really interesting that they're still staining positive for glucagon in the pancreas. Now, whether they're releasing the glucagon, even if they stain positive, could they be silently staining but not releasing the glucagon? I don't know. Anybody else who would like to think about that?
And it looks like we have Dr. Yajnik, you have your hand up. Did you still have another question or?
Yeah, this was about fatty acids and ketosis resistance. So we have a second paper. You showed the first paper, which was just observational. Then we had a second paper where we infused intralipid into type 1 and FCPD patients to raise their circulating triglycerides and fatty acids. And doing that also, the FCPD patients produced much lower levels of free hydroxybutyrate. And therefore, we concluded that there was some problem with beta oxidation in the mitochondria. And now, having worked with FCPD 30 years ago and now working with vitamin B12 deficiency across the range, one of the enzymes which vitamin B12 regulates in addition to methionine synthase, where B12 and folate both act, the other one is a mutase, which converts propionic acid to succinic acid, which enters the mitochondria through the CPT1 and 2. And I think actually pancreatic problems is a very high risk factor for B12 deficiency. And that might actually add to the problems of transferring the fatty acids into the mitochondria because that enzyme is not active. And I have planned to do this, to inject vitamin B12 into these patients and study their intralipid infusions before and after, which I think you can do because I don't have many patients now. And one way would be, of course, to measure B12 to see whether they have low, which I suspect they will be low. So it's something to do with beta oxidation, very likely.
Thank you for that. In fact, B12 deficiency is common.
Yeah.
Having said that, I mean, there's a lot of B12 deficiency still moving around with everybody else. And so I'm not sure whether it is more common in the FCPD. One would, of course, expect them to have some degree of malabsorption, which may be there in addition to just the fat malabsorption.
Yeah, B12 malabsorption due to lack of pancreatic enzymes, which are necessary to break the B12 from the complex with intrinsic factor. So that's a classic textbook condition which is associated with B12 deficiency.
Great. Professor Thomas, I think we'll wrap up now. Thank you so much for your time and your extra time. Appreciate you joining us today for this excellent webinar. And thanks for everyone who is still logged in. So I would just want to let you know that we will send, we'll have this link of the recording of the video up on our website in a couple of days, and we'll send an email to everyone with the link in case you want to share it with others. So thanks once again. Do you have any final words, Professor Thomas?
Yeah, thank you so much, Mark, for this wonderful opportunity. It's been a wonderful discussion with all of you online scientists, clinicians, everyone, and look forward to interacting with you again. Thanks so much. Bye-bye.
All right. Thanks. Have a good evening and a good day, everyone.